talk where there are natural breaks, so we will pause and see what questions you might have. So I'll just share the screen and we'll get underway. This is just this is where I live. This is Auckland, New Zealand on a particularly nice day. Yeah, I hope, you know, just like the before times, that some of you at least are eventually able to come and visit us here. But right now, we're here to talk about biomarkers to predict motor recovery and outcomes after stroke. And before we get too far into it, I'd really like to acknowledge some of the colleagues that have worked with me over the years on this. Dr. Marie-Claire Smith, Suzanne Ackerley, Professor Winston Byblow, and Professor Alan Barber, who are all just instrumental in this work. I'm just the lucky one, really, who gets to share it with you. And most importantly, the many hundreds now of patients and their families at Auckland City Hospital who've very generously given their time and energy to the research that I'll show you. It always amazes me that people are willing to say yes to research participation just within days of what could be one of the worst things that's ever happened to them. It's a remarkable generosity. So here's the outline of what we're going to cover today, and after each of these sort of main points there'll be an opportunity to pause and hear what questions you might have. So first we're going to start with predicting recovery and outcomes after stroke. And it's pretty important to get our terminology right. So we're going to start with what exactly do we mean by these words. So here are three not hypothetical patients. These are real patients. You can see that just within a couple of days of stroke, they've all got different scores on the upper extremity Feeble-Meyer score, a measure of motor impairment. But by 3 months post-stroke, they've all got the same score. So they have different recoveries because recovery is how much you improve over time. They've all improved by different amounts, but they have the same outcome because they've all landed in the same place. Conversely, these three patients, also real but just different to the first three, all have the same recovery because they've improved by the same amount over time, but they have different outcomes because they've all landed in the same place at 90 days. And I know this just sounds a little bit pedantic, but it is really important to understand, are we predicting recovery, which is how much you'll improve by, regardless of where you start and finish, or are we predicting outcome, which is where are you likely to be in a certain amount of time, regardless of where you've started. And for some people, their outcome is the same as their baseline, so effectively they haven't recovered. Anyway, just to clarify the language that will be used. Okay, so there are several already quite well-established predictors of stroke outcome. These types of things are well known to affect outcomes after stroke. There should be no real surprises in this list. But the thing is that they're related to outcome measured using something usually like the modified Rankin scale, which you're probably familiar with. This is a 7-point ordinal scale that ranges from a 0 for no symptoms for 6 to dead. So it's not particularly sensitive. It's a very coarse scale, and there's a lot of different factors, not just your neurological functioning, but a lot of other factors, cultural and social ones, that can also influence what grade a person is at. So this is okay. These predictors are all right. MRS is all right. But we're really interested in something a bit more specific, and that is predictors of motor outcome in particular. And we're really focused on motor function, recovery and outcomes, because motor function is the most commonly impaired domain after stroke. Something like 3/4 or around 80% even of patients have impaired movement after stroke. Recovery of movement is critical for regaining independence in daily activities. Walking is actually the most commonly expressed rehabilitation goal for people after stroke. They want to be able to walk by themselves again. And independence, though, interestingly, at 6 months post-stroke, independence really depends on these three things, and that's your upper limb motor performance, your age, and your stroke severity at baseline, back at the beginning. Now, we can't actually do anything about your age and your initial stroke severity, which means that your independence in daily activities really depends quite heavily on how well your upper limb recovers. This often surprises people. They think independence is really all about your ability to walk around. No, you really do need two hands to do most of your daily activities. And if you're not sure about that, just try getting into your jammies tonight using only one hand. It's extremely frustrating. Okay, So the problem really is that prediction is very difficult. So here's some data from a study published a few years ago now, where experienced physiotherapists were asked to predict the action research arm test score at 6 months. So within a few days of stroke, they were asked, what do you think your patient will be doing in 6 months' time, measured with this thing, the ARAT? Now, the ARAT is scored out of 57. 57 is normal motor performance. It's what most of us would probably score today. And it's a measure of upper limb capacity. And they made it actually sort of easy for the therapist. They said you've got three options. You can say that in 6 months they'll have a score less than 10, which means they are obviously quite impaired. They'll have a score of 57, which is perfect. They're basically going to get back to normal. Or they'll have a score of 10 to 56, which is a bit like saying, I don't really know. We're just going to put them in all in this gigantic middle category. They won't be sort of terrible and they won't be perfect, just somewhere in the middle. So how did these therapists do? Well, they were actually not bad at predicting who would not have a good outcome at 6 months. They were not good at this very big middle group, and they were a bit better for being able to predict who would have a complete recovery. Overall, they were just a little bit better than chance for this whole group of patients. And the problem really is this big middle group. I mean, you might as well flip a coin. Honestly, therapists don't know. And it's troubling because if you ask them, they think they do know. Their confidence sort of exceeds their ability here. And a lot of clinical decisions are made based on these expectations for recovery. So it is an issue. And all of these therapists had at least 20 years experience in neurological rehabilitation. So it's not that they were just making rookie mistakes. So prediction is hard. That's for the hand and arm. Another question that we've asked therapists is, when do you think your patient will be able to walk by themselves again after stroke? Now, this is a different way of looking at the data. I'll explain what you're looking at. This is a Sankey diagram. On the left-hand side, P means the prediction. And so the therapist had these options. They could say, my patient will be walking safely on their own again within 4 weeks, 6 weeks, 9 weeks, 12 weeks, 26 weeks, so that's 6 months, or at 26 weeks, they'll still be dependent. And then we looked at what actually happened. So P is for prediction and A is for actual. And you can see, let's just take these sort of teal blue ones as an example. You can see that all these patients, it's all scaled relative to the number of patients, by the way, but all of these patients, the therapist said, yep, I think they'll be walking within 9 weeks. And you can see that some were walking within 4, some were walking within 6, some were right and were walking within 9, so between 6 and 9. Some took 26 weeks to get there and some were still dependent at 26 weeks. So the therapist could make this prediction of 9 weeks, but that patient could land almost anywhere. And we have a similar problem here in this sort of gold color. So this is spaghetti, this is a mess. And it reflects that, again, therapists really aren't that good, even experienced therapists, at predicting how long it will take for their patient to be able to walk safely on their own again. So it's hard. It's just clinically really hard. And the reason for that is that patients who are performing in a very similar way at that acute stage within the first few days can have very, very different recoveries and outcomes. And the best way, I think, to illustrate this is with this data set. Every line is an individual patient, and we measured their action research arm test score at 2, 6, 12, and 26 weeks post-stroke. And you can see that as a group, sure, everybody typically improves to some extent. On average, the group improve and recover. But if you take two patients who have a similar starting point, you can see one has a good recovery and a good outcome, and the other one really doesn't improve much at all. You can take another two patients and they're absolutely striking in terms of the difference in their recovery and outcomes. People who really worry us clinically, I think, are these ones in the bottom left-hand corner, because 2 weeks after their stroke, they have almost no movement. But one of them is going to go on to have a good recovery and a reasonable outcome. The other one won't improve at all. The problem is you cannot tell by looking at them, because in terms of what they can and can't do at the time, back at 2 weeks, they're actually the same. right? So this is really challenging, and it really undermines the confidence of therapists, because they'll start treating these two patients, and one will do well and clearly improve, and the other one will not improve at all. And it's easy for the therapist to really start to fret about, well, what am I doing wrong with this patient that's not improving? I'm trying everything. Am I doing the wrong combination? Am I not doing enough? So it's quite it doesn't engender a lot of confidence, particularly for more junior therapists, these sorts of situations. So it's a problem. So I'm going to pause there, because I hope I've shown that predicting recovery and outcomes after stroke based purely on clinical experience and clinical impression is a bit sketchy, to be honest. We're not very good at it, even with a lot of experience. I'm just going to pause there in case there's any sort of burning questions to cover. You guys are all looking to shout, I guess. Really know how this works. Okay, if you're happy, you appear happy. Just checking the chat. God, come on, Zoom. Okay, no, we're fine. All right, let's carry on. So the next bit is, okay then, what if we had biomarkers that could help us tell what somebody's likely recovery and outcome is going to be? Well, first we need to think about, well, what's a good biomarker going to be? What is a biomarker? Might be a better question. So a typical definition looks like this. It's a defined measure derived from molecular, histologic, radiographic, or physiologic characteristics. So it's something that is objectively measured from the body. It's an indicator of any of these things, normal biology, pathology. We're kind of interested in response, or in response to an exposure like a treatment, for example, or something that will predict the natural course of recovery. It's important to remember that biomarkers are not clinical outcomes. They're not the sorts of things that we measure progress and outcome with. So it's not about how a person's feeling, it's not how they function, and it's not whether they survive. So all of those clinical assessment tools, they might have some predictive value, but they aren't biomarkers. Okay, so there's a couple that we'll cover today. I'm putting these two together as neurophysiological biomarkers. Some would argue that EEG actually falls into imaging, but the neuroimaging biomarkers that have been looked at for stroke are things like various flavors of MRI, as well as CT imaging. So I know that you've probably got reasonable familiarity with all of this, so we'll just sort of whip through it. It is important to know as well, though, that there's a difference between types of biomarkers. So prognostic biomarkers tell you about the likely outcome with standard care. So no particular intervention, just what's the prognosis for this patient. Whereas a predictive biomarker is one that predicts the likely benefit of a specific intervention. Right, so these types of predictive biomarkers are often used to select patients for trials or for specific types of therapy or treatment. A good example of that in the hyperacute stage is that neuroimaging is used to select patients for clot retrieval, right, to remove the clot within the first few hours after stroke. So what's seen, usually through CT angiography, it's incredibly important for that decision making. Okay, so TMS biomarkers, things I'm sure you're aware of. The one that we use most heavily is just the presence or absence of a motor evoked potential in the muscles of the paretic or affected upper limb. We typically use first dorsal interosseous and extensor carpi radialis. And it really is that simple. Is there a response or not? It's disappointingly simple. All of my expert neurophysiology colleagues are quite disappointed that we're doing something kind of that basic, but it really is very useful as a biomarker. Other options are to look at the threshold, rest or active motor threshold for producing MEPs, the latency of those MEPs, the amplitude of the MEPs. But of these four, the most evidence has accumulated simply for the presence or absence of MEPs. The additional information provided by these other measures actually isn't nearly as predictive as the presence or absence of MEPs. So MEP presence or absence, It will come as no surprise to you to hear that MET positive patients, so patients in whom TMS can elicit a response in the muscles of the paretic upper limb, will have a better motor recovery and outcomes than MET negative patients. This has been shown time and again for the upper limb. We've done some work on it over the last decade, but heading back 30 years, this was already known in the literature. It's much less clear in the lower limb. And MET presence, or MET status, I guess we call it, has a high negative predictive value, which means if you don't have MEPs, if you're MEP negative, you're really not going to recover individuated finger movement, but it has only moderate positive predictive value. So if you do have MEPs, it's not a guarantee that you will do well and recover fine motor control, right? Some patients who are MET positive still don't make as good of a recovery as other people who are MET positive, so it's more variable. But it's still, MET presence or absence is still one of the best TMS biomarkers we have, and it's very, very simple. Structural MRI biomarkers have also received a lot of attention. The main ones people have looked at are lesion volume, corticospinal tract lesion load, and I'll just show you this to illustrate what I mean by that. So in green, we've got the uninjured corticospinal tract descending from M1. Red is the stroke lesion, and yellow is the overlap. So that is the lesion load of the stroke lesion directly on to the descending corticospinal tract. You can see that the person on the left has a much smaller lesion load than the person on the right. And another very popular metric is fractional anisotropy asymmetry, typically of that same descending corticospinal tract, and looking at the asymmetry between the hemispheres. Of these three, CST lesion load, again, probably has the most evidence accumulated in favour of it as a useful biomarker. I'll illustrate that with some work from Wayne Feng from just a few years ago now. This is a really busy figure, just bear with. So these top two patients, A and B, have roughly the same lesion volume, about 140 to 150 cc's, but they have quite different weighted lesion loads. So the overlap between the lesion and the corticospinal tract in red is much more for patient A than it is for patient B. And you can see back here that at 3 months, patient B is doing much better on the Fugl-Meyer. The maximum score is 66, and also much better on the NIHSS, the stroke scale, where lower scores are better. So while they have the same-ish lesion size, it's the difference in their lesion load that is really driving these differences, particularly in upper limb motor outcome. And if we flip it around and look at B and C, patient C has a much smaller lesion volume, much smaller, but a heavier lesion load. Small lesion, but it happens to be in exactly the wrong place. And so as a result, they're not doing as well at 3 months on either of these two measures, right? They have worse outcomes. So the point of this is that lesion size or volume, really not that important. It's location, location, location. The extent to which that lesion intersects that critical descending corticospinal tract, that really has a big influence on Fugl-Meyer scores in particular. So just looking at the same data set from the same people, patients with less lesion load on the corticospinal tract have better motor recovery and outcomes. Again, for the upper limb, much less is known about lower limb. And you can see here that these patients with the smallest lesion load are all generally doing pretty well. Patients down this end with a higher lesion load are not doing so well, but unfortunately there's this sort of big group in the middle, somewhere between about 3 and 5 cc's. They can have any, honestly, they can have any outcome, right? So it's a little bit grey. So these types of metrics, CST lesion load, have good relationships at the level of the group. You can draw a nice line through it, but they don't have a lot of usefulness at the level of individual patients because there's no clear cutoff. There's no way of discriminating patients that well in this middle range in particular of lesion load. So the usefulness is not quite so straightforward. So just returning for a second to MEP status, where CST lesion load reflects the structural integrity of that critical descending tract, MEP status reflects the functional integrity of that critical descending tract, right? And it predicts rather the potential for recovery of individuation and fine motor control, because we know that the CST, that monosynaptic pathway, plays such a critical role in fine motor control. So what it means is that these MRI biomarkers don't actually add any value when patients are MET positive. If you can get a response to TMS, it doesn't matter what the tract looks like on a scan, because it's working. If it works, it works. It doesn't really matter what the structural metrics are. So but the MRI biomarkers are related to outcomes when patients are MET negative. Now they contain information. So I'll just illustrate this with this unfortunately lower resolution than anticipated figure. So along the x-axis again we have CST lesion load, and it measured in a slightly different way to Feng's paper, 90-day upper limb Feeble-Meyer score. And you can see that in general these MET positive patients in blue generally have scores that are higher than MET negative patients in orange, and that's as we'd expect. Down this end with low lesion load, MET positive patients always do better than MET negative ones, right? And down the other end, the same is always true. This line here, the blue dotted one, that's not significantly different from 0. So it doesn't matter what your lesion load is on the x-axis, you're going to do well if you're MET positive. Whereas the orange dotted line is significantly different from 0, which means that if you're MET negative, the higher your lesion load, the worse your outcome will be. And it sort of makes sense. The structural integrity only becomes meaningful if it's completely stopped working. And it's probably because that lesion load is picking up on the damage to other types of pathways passing alongside and sort of entangled with the CST. Yeah, so it's important to see how these two types of biomarker can actually work together. So what makes a good biomarker then? Well, it needs to be something that's readily obtained early after stroke, because early after stroke is when all the decisions are made clinically. There do need to be some fairly clear cutoffs. So that big sort of grey zone in the middle for something like lesion load on its own can be a bit unhelpful. It needs to predict something useful. And so far, all I've shown you is things that relate to 90-day Feeble-Meyer upper extremity score. I'm not sure how useful just predicting the number on that scale is for an individual patient. And so biomarkers probably need to be combined with other factors together to become useful in both a clinical and a research setting. But I hope I've shown you in this section that both MEP status and measures like lesion load on the corticospinal tract, they have different strengths, and between them, they can offer us quite a lot of information. So again, I'm just going to pause there. We've covered why is it hard predicting recovery and outcomes. What are we looking for in a biomarker? And I've offered you a couple of examples from TMS and MRI. And we're going to look forward now to what makes a good prediction tool. How can we combine some of these things into a tool that becomes useful? But I'm just going to pause here again in case there are any sort of burning questions or concerns. I don't know how this works. Hello, Colin.
Hello, Cathy. I just have a question regarding the MEP development, so MEP positivity of stroke patients, because typically that seems to me something like that could change drastically between the early stages of stroke and the late stages of stroke. So patients who maybe at first, is it possible that a patient shows MEP positivity at first, but then later on not, or probably the other way around is more common, that they don't show MEP positivity at first and then later on? And how would that affect the prognostic or predictive value of the marker?
Thank you. Great question. So the good news is we haven't found anyone yet who's positive and goes negative. Thank goodness. And I guess that's because the acute damage of the stroke is over. And if you've got through that with a functionally intact CST, then you're probably not going to lose it. So that's good. It is true that a small percentage of MEP negative patients can become positive down the track. What is so interesting about these patients, and we found this in our own work, and also Jingshu and Heidi Shambra in the States have recently, about a year ago, published something along these lines as well, that people who are MEP negative within the first sort of week-ish, which is when we do all of our testing, if they become MEP positive, it doesn't really help them. And so we think what that means is that their MEP status within those first few days of stroke is really a biomarker of the extent of damage, right? And so if you are able to regain MEPs down the track, you still had the same severe level of damage back at the beginning. That's what that MEP negative status was really telling you back at the beginning. And so, yeah, that's kind of a slightly disappointing bit, that people might eventually recover MEPs, and when they do, they're far from normal, very high thresholds, very delayed, but they can come back to some extent, but it doesn't seem to change their recovery and outcomes. Does that answer your question?
Yes, that does answer my question. Thanks a lot.
Cool. Yeah. Any other burning points before we get to the next bit? No, you're okay. There'll also be time at the end. Okay. So what makes a good prediction tool? Well, good question. So prediction tools, Bokyu Kim and Carolee Winstein, a couple of years ago now, produced this just wonderful review, and all the references are at the end of this talk if you're interested, which reviewed all of the neurological biomarkers in depth. So I really encourage you to look at that if you're particularly interested in the different measures you can use. But they argue quite well for the need to combine these sorts of neurological biomarkers like TMS and MRI metrics with things like demographic information and clinical assessment, pull it all together to be able to accurately predict outcomes after stroke. And that's certainly the approach that we've been taking. We think this is worth doing because it lets us clinically optimize rehabilitation planning and provision. We'll speak more about that in a few minutes. And we also think it could help us improve the way we select patients for recovery and rehabilitation trials. And I'll show you some data that I hope will convince you of that. So what are some of the key characteristics then of a prediction tool for it to be useful? Well, it needs to combine clinical factors and biomarkers in a really systematic way. And so typically people devise scores, decision trees, and algorithms, which are sort of a protocolized way of bringing together this information. And again, I think these can be very useful for clinical trials and practice. So here are some key characteristics. One is prediction tools need to predict the future, not the present. I know that sounds ridiculous and obvious. You'd be amazed at how much research gets published saying, look at these amazing predictors we found. They are predictors in a statistical sense only, and that they predict something. They account for variance in a model, but it's a cross-sectional study. So they're not predicting a future time point, right? They're related to measures that were made at the same time that the predictors were measured. So I know it seems obvious, but if you're looking at this sort of literature, just be sure that they're actually predicting the future, not doing correlations at the present time. Yes, cross-sectional correlations are actually pretty unhelpful. They need to be used in the first few days post-stroke, and this is because clinically this is when all the decisions are being made, right? So does this person have rehab potential? Should we be sending them for a spell of rehabilitation or not? Are they going to private hospital where they'll actually receive very little therapy, potentially, depending on your healthcare setting? So it's really important that this is done early, that's possible to be done early. It's also true for clinical trials. Increasingly, trials need to be initiated early so that the thing you're testing has a chance to interact with the spontaneous processes of recovery, interact with that biology. So yes, they need to be used in the first few days. They also need to make a prediction for a specific time post-stroke. So a lot of research gets done which makes predictions for outcomes at discharge from the hospital, particularly discharge from rehab. This is entirely circular, right? Because people are often discharged when they achieve a certain outcome, when they achieve a certain level of function, that's when they're allowed to leave, right? So you're predicting what will they have at discharge, but you kind of know what they have to have at discharge because that's why they're being discharged, and it goes round and round. So it's also very dependent, people's level of function on discharge is very dependent on local healthcare settings as well as the local culture. So not good. It's much better to find and use prediction tools that are making predictions for specific times post-stroke, such as 3 months or 6 months. They need to predict something meaningful for the patient, these tools. A number like, oh, we think you're going to have a Fugl-Meyer score of 43, plus or minus 2. There's no world in which that conversation is going to take place with a patient, because it means absolutely nothing to them. What they want to know is, what will I be able to do, right? Am I going to be able to look after myself at home? What things might still be challenging for me? Right? So predicting scores actually isn't helpful. And finally, prediction tools need to combine a small number of factors easily. So things like this, which are the sorts of things that get published, actually are not super helpful, because there's not many clinicians in particular, or even clinical researchers, who are going to whip out their calculator and try and figure this stuff out. And even if they do, they're going to be predicting a score. And again, the meaningfulness of that to the patient is questionable. Right, so it needs to be easily used, such as an easy to remember decision tree or an app that you can plug values into. Okay, so that's what we're looking for in prediction tools. I'm going to give you some examples that we've been working on. So for the upper limb, we've developed something called PrEP2, which is predicting recovery potential 2, because we've updated the model. It predicts 1 of 4 upper limb outcomes at 90 days post-stroke, and it's used within 7 days post-stroke, so it's nice and early. This is really just a timeline of its development. So this is how we got there through several pieces of research. Along the way, we've written some reviews of what we're doing, and then it's been very rewarding to actually implement it in 3 hospitals here in Auckland, and also publish about that implementation process. So this is really just to give you an idea of, if you're thinking about developing and implementing a prediction tool for the real world, oh gosh, it took me a lot longer than I thought it would. It's quite a big job. And we're really still only just getting started, to be honest. So what does this thing look like? Well, it looks roughly like this. On day 3, we assess patients' upper limb power, motor strength. So SAFE stands for shoulder abduction, which is that movement, and FE is finger extension. These are each graded out of 5. 5 is the best score, and added together for a SAFE score out of 10. If the patient can achieve a score of at least 5 by day 3, we can safely assume they're MET positive. They do have a functional corticospinal tract. And if they're young, which in stroke land is under 80 years old, then they're most likely to have an excellent outcome for their hand and arm. And I'll show you in a minute what excellent sort of really means. But if they're a bit older, they'll need a SAFE score of at least 8 on day 3 to achieve that same excellent outcome. Otherwise, they're most likely to have a good outcome. Now, about 2/3 of patients come through this top half of the prediction tool, which means our therapists can make a prediction in about 3 minutes for most people. So that's great. Patients who on day 3 are still very weak and have a SAFE score under 5, they need TMS. And if they are MET positive within the first 7 days of stroke, then they're still most likely to have a good outcome, sometimes even excellent, because they've got a functional corticospinal tract. What's exciting about this group of patients is that they can have SAFE scores as low as 0, not even a flicker of voluntary muscle activation. But if we can get a response with TMS, they're still on track to probably have a good and possibly excellent outcome. It's very rewarding to be able to tell patients and families that things look a bit grim at the moment, but the connections still work. And so let's work really hard with your therapy to maximize that potential for recovery. Patients who are MET negative have obviously sustained a fair bit more damage to those descending motor pathways. Now it all depends on the overall severity of their stroke. Low scores are good on the NIHSS scale, and if their score is less than 7 back on day 3, they're most likely to make have a limited outcome. If it's 7 or more, they're most likely to have a poor outcome. About 1/3 of patients need TMS, and about half of those are MET negative and receive a limited or poor prediction. What's important about this part of the pathway is that these people have quite severe initial impairment, and a lot of important rehab decisions are being made with them in that first week. So it's important to know if they're MET positive or not. That will have a big impact on what the goals for their therapy are. It's also useful to know that overall, this tool has an accuracy of about 75%. It's uneven though. You can see it's more accurate in some areas than others, for some categories than others. But what's important is that people in these sort of most negative categories, limited and poor, that's where it's most accurate. So when we are giving people these predictions, we can do so with a great deal of confidence. Okay, so that's what PrEP 2 looks like. This is with the TMS part. So we use TMS for about a third of patients. And in the first version of PrEP, we actually had CST lesion load in here at this step. And there was a measure of lesion load which would stream people into either limited or poor. But we discovered that the NIHSS score performed just as well, was just as accurate. And it's obviously a lot easier to obtain than an MRI scan and some advanced processing of that scan. So that's why for clinical use, we recommend using this version of the prediction tool. Okay, so that's the upper limb. I mentioned that I'd tell you a little bit about what the outcomes are. So these are the outcomes and the scores, the bands of scores on the Action Research Arm test. So excellent means the person will be able to use their hand in usual daily activities almost normally. Good means they'll be using their hand and arm in usual daily activities, but it will still be experiencing some effects of the stroke. Limited means they'll have limited use of that hand and arm. They might have some sort of grasp, sort of gross hand opening and closing, and be able to get it incorporated in some bilateral activities. But because they don't have a functional corticospinal tract, they will not be recovering independent finger movement and fine motor control. And people in the poor group have minimal return of movement without really any use of their hand and arm. We've put a lot of work into thinking about how to communicate these messages in a psychologically safe way to patients and their families. There's a lot of effort goes into getting that right. So, as I mentioned, PrEP 2 predicts one of 4 outcomes. It's used early after stroke. It makes predictions for a specific time point post-stroke at 90 days. Those 4 categories are functionally meaningful to patients. And those are easily remembered decision points. This doesn't need to be written down for the therapy teams. So it ticks several of the boxes of what makes a good prediction tool. We've also been thinking a lot about walking, and we're in the throes of validating something called TWIST, which is the time to walking independently after stroke tool. This predicts whether and when a patient will recover independent walking with a functional ambulation category more than 3. Again, it's used 7 days post-stroke. So the first version looks like this. Starts with the trunk control test. This is out of 100. This, if you're not familiar, this just involves literally what it sounds like, trunk control, rolling to each side, in the bed, sitting on the side of the bed. Patients who can score at least 40 out of 100 will be walking safely on their own within 6 weeks, 90% of them, regardless of how weak their leg is. It's amazing. You need your trunk to be able to mobilize. Your leg can be very weak and you will still recover that ability. Patients whose score is lower than that need good hip extension, right? If they do have good hip extension, at least a 3 out of 5, they'll be walking on their own within 12 weeks. Otherwise, they'll be dependent at 12 weeks. This is a bit rough and coarse. We've just completed another study with 4 times as many patients, and we've refined this and we have more prediction time points now. But what's important to notice is that this version of TWIST and the one we've just completed does not use TMS or MRI. We have that biomarker information. We've made it available to the machine learning that comes up with these decision trees. But they're not selected. Those biomarkers are not selected as important predictors. And it probably comes down to the organization of the control of walking, which is much more bilateral than it is for fine control of the hands. So we think that those differences in sort of neuromotor control account for the differences in how useful these biomarkers are for walking. Okay, I showed you this before. This was therapist predictions for when will people be able to walk, predicted for P and actual there in A. This is what our early version of TWIST does. Now look, it's not ideal. There's definitely room for improvement here, but the spaghetti is a little bit better organized on the right than it is on the left. So we think we're heading in the right direction with this. These TWIST predictions are definitely more accurate than therapist predictions. So that's going in the right direction. So TWIST, yep, time to independent walking within 7 days post-stroke. It makes predictions for specific times. Independent walking is functionally meaningful and the most sought after rehab goal for patients. And the predictors are easily obtained. These are 3-minute bedside clinical assessments. It's very straightforward. So again, as a prediction tool, Twist is ticking at least some of those boxes. So we're continuing this work. Okay, so that's what makes a good prediction tool, and some examples from the sort of work that we've been doing. So again, I'm going to pause there. The last little section is quite brief. So if anyone has any burning questions on that section, we can pause here, or you can save it until the end. Yes, deathly silence. Okay, I'll assume that's okay. We'll carry on. We're nearly there. So the last little bit is, well, how can we use biomarkers potentially to improve our research and clinical practice? Well, prediction would improve trials for sure. And I mentioned before that I do think there's a really important need to test new treatments, whether they're pharmacological, neuromodulation, different kinds of therapy, whatever they are, to improve motor recovery and outcomes after stroke. We need to be testing them at the subacute stage. We did a review a few years ago in stroke and found that over half of the clinical trials out there for improving motor performance after stroke were done at the chronic stage of stroke. It's not helpful, because that's not when rehab is delivered in the real world. Rehab starts within 2 or 3 days after stroke. That's when we need to be testing our treatments, because that's when they will be used eventually in the real world, right? So that's the time to focus. It's tricky though, because when you start early, everybody's improving to some extent. So you have to detect the effects of your intervention against this background of improvement. And that improvement, as I showed you earlier, is highly variable from person to person. What trialists typically do is they balance their two groups, their treatment group and their control group, on baseline characteristics. They say, look, baseline Fugl-Meyer score was an average 20 points in this group and 19.5 in this group, so the groups were balanced. That's great. That might be true, but they might not be balanced for their potential to recover. They just through natural processes, they might not be balanced in their potential to respond to the particular treatment or intervention that you're testing, right? So it's actually really important to instead balance our groups on their likely recovery and outcome, as well as their baseline characteristics. Otherwise, you could, for instance, have a whole pile of MEP negative patients in your treatment group who can't physiologically respond to the treatment that you're testing. And so this might weaken your ability to detect a benefit of your treatment. Or it could go the other way, and you might get a whole bunch of MEP negative patients just by chance in your control group, and that might make the treatment look a lot better than it really is by comparison. So you really do need to know what people's potential is, and the biomarkers I've shown you are a good way to establish that. Here's just a little bit of data to sort of hopefully make the point as well. So we had a sample of 207 patients. This is just some of their baseline characteristics. They're a pretty unremarkable group. This is pretty typical looking for a stroke cohort. And what we did was we then looked at only the patients who were MEP positive, right? So there are 30 MEP negatives, so we just looked at the ones who were MEP positive, and you can see that they're actually quite similar in terms of the range of scores on the NIHSS and also the range of scores on the Fugl-Meyer scale. So you would say these two groups were matched at baseline, that they're actually not. This group's all MEP positive. So then what we did was we took the full sample and the MEP plus only patients, and we calculated based on their 90-day data, what would our sample size need to be to detect a 7-point difference in Fugl-Meyer score between a hypothetical treatment and control group at 90 days? So just a completely hypothetical situation. 7 points because that's commonly accepted as a clinically important difference between groups. And we wanted to know what happens to sample size and what happens to the relative time to recruit such a sample. So here's what we found. I'll just talk you through this. So we looked at the full sample of patients. We bootstrapped to find an estimate of the mean of their Fugl-Meyer score at 90 days and the estimated standard deviation at 90 days. And then we did the same thing just for the MEP positive only patients. And you can see that straight away, if you select MEP positive only patients, you drastically reduce the variance in the standard deviation in outcome at 90 days, right? So these are the numbers you're going to use to calculate your sample size to work out what do I need to detect a 7-point difference. So if you do that exercise, I've just done this for 2 different levels of statistical power, you can see very, very big differences in the required sample size. If you recruit MEP positive only patients, you will need about 1/4 of the sample size to detect the same effect between your treatment and control groups. 1/4. Think about what that does to your budget for your project you're planning. And if you think about the relative time to recruit, so this is just relative to the full sample, it's going to take you about 1/3 of the time to find these people. Amazing. That's a massive increase in the efficiency of your trial, simply by selecting the MEP positive patients. Great. And if you look at a different outcome, like the Action Research Arm Test score at 90 days, you see the same pattern of results. You roughly halve the variance, you need 1/4 of the patients, and you'll recruit them in 1/3 of the time. Simple biomarker, just use that. Okay, so prediction would improve trials. If you use MEP status to select participants, this matches your groups for predicted recovery and outcomes, right? You've got far more homogeneous groups. That decreases your variability, increases your sensitivity to the effects of your thing that you're testing, reduces your sample size by 75%, which is big, and it also reduces your study duration and costs. So suddenly your application is going to look pretty competitive compared to all the others in the funding round. So I hope that is reasonably compelling. Okay, so in summary, what have we covered? Prediction tools are being developed for stroke rehabilitation. MEP status is a useful prognostic biomarker for the upper limb to predict outcomes. We use it as part of the PrEP2 prediction tool, right? It is important to embed it with those other key factors into a prediction tool. This is improving clinical care because it reduces guesswork and it helps manage everyone's expectations for the patient's recovery. It can also improve biomarkers like MEP status. I think I've shown you can also improve the sensitivity and efficiency of rehabilitation trials, making them much more cost effective. That's all I have. Thanks. Another view of Auckland. Okay, I'm going to stop sharing and be interested in any comments or questions. Thanks, guys.
Well, thanks a lot, Cathy, for the brilliant talk. I really learned a lot, and I think I will just open right away with a question, and then everyone else can chime in if they have questions too.